Let's talk about stroke, baby. Let's talk about you and me. Okay, so today we are going to talk about ischemic stroke. So there's two types of strokes. There's hemorrhagic and ischemic. So hemorrhagic is when you bleed, and ischemic is when you clot. So types of ischemic strokes are atherosclerotic and embolic. So atherosclerotic means that it was already there, so the cholesterol and all the junk was all built up in the blood vessel and it just occluded. Whereas embolic means it came from somewhere else. Ooh. So AFib, you have quivering atria, and that causes the ventricles to pull blood, and when blood pulls and becomes stagnant, it clots, and then when it squeezes, it can shoot it up to the brain, causing a stroke. So, embolic, cardioembolic, actually. So, let's talk about the risk factors of stroke. So, there's non-modifiable and modifiable, and then modifiable can be broken up into disease states and lifestyle. So, non-modifiable, we've got age, family history, gender, so if you're male, race, if you're African American, Asian, or Hispanic, or if you were born with a low birth weight. Modifiable disease states, diabetes for sure, keeping that A1C less than 7, hypertension, getting that blood pressure less than 130/80, hyperlipidemia, being on a high-intensity statin if you have cardiovascular disease, your LDL is greater than or equal to 190, we have diabetes and an ASCVD risk of greater than 7.5%. Being on that high-intensity statin. And then cardiovascular, so AFib if you're rate and rhythm controlled, as well as anticoagulated if your CHA2DS2-VASc score is high enough, which we will get to. And if you have valvular disease, you need to be on warfarin, basically. That means like if you have a valve replacement, blah, blah, blah. Lifestyle, so smoking cessation, obesity and inactivity, and illicit drug use. Don't use cocaine. So let's talk about AFib, because AFib is a leading cause of stroke, one of the leading causes of stroke. So how do you know if you anticoagulate on if they have AFib? So it's a scoring system. It's called the CHA2DS2-VASc score. The C stands for CHF, or low ventricular dysfunction, left ventricular dysfunction, ejection fraction less than 40%. 40%. Hypertension, age, if you're greater than 75, you get 2 points. What's next? Diabetes, if you have a history of stroke, TIA, or thromboembolism, you get 2 points as well. Vascular disease, so if you have an MI, peripheral artery disease, or an aortic plaque. And then age again, if you're 65 to 74, you get a point, and then if you're female, you get a point. So if you have 0 points, you can just stay on aspirin. Yay! If you have 1 point, you could be on aspirin, or you could be on anticoagulation. Now, if you have a score of 2 or greater, then, sorry, you're anticoagulated. So when do you take aspirin? So women with a high CV risk need to be on aspirin. Men do not unless they have cardiovascular disease. Presentation of a stroke, everyone knows we have this dysphagia, difficulty swallowing, facial numbness, can be unilateral or bilateral, weakness in one side, ataxia, so muscle coordination is messed up, double vision, diplopia, or a headache, which is more common in hemorrhagic strokes, but you can still have a headache. Scoring, symptom evaluation, you need to know when the symptoms started, so time of onset. And there's also the National Institute of Health stroke scale, the NIHSS, that is used to evaluate patients. So evaluation, so imaging is very important. So you can do a CT of the head, or you can do an MRI. MRIs tend to be better at catching strokes. You need to monitor their blood pressure and their O2 sats. Labs, you need to make sure that their blood glucose is less than 180. Need to get a BMP, a CBC, and then hematologic markers like PTT, APTT, and INR. And then you can do an EKG, an echo if they have heart failure, and a swallow test, because if you have dysphagia and you're eating food, you could aspirate, get pneumonia, and die. So, patient comes in with stroke, symptom of onset, 2 hours. Guess what? TPA, thrombolytic, alteplase. So there's a 3-hour window for patients that are 18 and older. There is exclusion, so if any kind of bleed in the last 3 months to 3 weeks, so for example, if you've had a stroke in the past 3 months, then you can't get TPA. If you had an MI in the last 3 months, if you had major surgery in the last 2 weeks. So just bleeding, anything bleeding, an active bleed, an ICH bleed. Or if your blood glucose is less than 50, your blood pressure is greater than 185 over 110, platelets less than 1,000, and you can't be on anticoagulation newly started. They will give you, if your INR is greater than 1.7, they will give you reversal, so vitamin K and PCC, just so you can get the TPA. There's an extended window to 4.5 hours, but there's more exclusion criteria. You can't be greater than 80, you can't have diabetes and a history of stroke, your NIHSS score can't be greater than 25, or if you're on any coagulation at all. So how do you dose alteplase, or TPA? So it's 0.9 milligrams per kilogram, max of 90. You give 0.1% or 10%, you give 10% a bolus over 1 minute and the remaining 90% over an hour. So patients 90 kilograms, is 100 kilograms. They get 90, so they get the first 10%, so 9 milligrams IV bolus. Then they get the remaining 81 over an hour. Side effects are bleeding. You want to keep blood pressure less than 180 over 105, and you need to watch out for cerebral edema. They could get a decompressive craniectomy if they need that. Thrombectomy. Thrombectomy is when they go in and take the clot out itself. They just bust it up mechanically. So you can, there's a window for this as well. It's 24 hours. You can do both a TPA and a thrombectomy at the same time. Not at the same time, but like for the same stroke. So it's pretty cool. But 24 hours, that's good stuff. Just to reiterate, blood pressure goals is less than 180 over 105. If they receive TPA, if they did not receive TPA, it's less than 122, 220 over 120. So platelets, antiplatelets. So there's different options after you have a stroke. If it's cardioembolic from AFib, you'd be anticoagulated, no platelets, antiplatelets. But if it wasn't, if it was straight up atherosclerotic, you'll be put on aspirin. So aspirin irreversibly inhibits COX enzyme, reducing TXA, reducing platelet aggregation. Or you can, if you were already on aspirin and you had a stroke, you can do you can do clopidogrel. So clopidogrel is a P2Y12 inhibitor that inhibits platelet aggregation by the blockade of ADP. Whew, that's a mouthful. But yeah, so you could do that. Now, if you fail both aspirin and clopidogrel, you could go to aspirin and clopidogrel, but there's not much data out there for dual platelet therapy. You can also use Agrinox, which is type dipyridamole plus aspirin. But this has been out of favor for a while. It gives you headaches. Nobody wants a headache. What's not recommended is prasugrel and ticagrelor. Those are the other P2Y12 inhibitors. Not recommended in stroke. Yeah, so that was ischemic stroke in a nutshell. Have a nice day.